In this slide, you'll see to the left an infant, and to the right, you'll see a senior individual. The two share a heck of a lot in common. Unfortunately, when drugs are produced, they don't consider these two age groups very well. They're not tested in these age groups, and for the most part, the literature doesn't really address how to deal with that. It's improving. There's some pediatric dosing and some senior care dosing that's now becoming available, but that's only recent. What these two share in common is the fact that the infant has organ systems that are only just developing. What I'm most interested in is the liver and also the kidney. So when you see a pediatrician dose a patient of this age, the first thing they do is they get out a calculator and they meticulously calculate the weight, the sex, all patient demographic aspects before they actually prescribe that medication. In the senior population, unfortunately, that's not happening. In the senior population, and the reason why they're related to the infant population is that they have the same problem, but in the reverse. Their organs are all on a decline. Their kidneys and their livers are very, very different than that of a 21-year-old. And this is what usually is not kept into consideration. So the geriatric population is a fragile age group from a pharmaceutical perspective, since renal function declines with the aging process. Most of the drugs and their metabolites have significant renal mode of elimination. Therefore, special attention needs to be given to drug selection and dosing. As a general guideline, I like to say that when you reach the age of 30, you begin losing renal function to the degree of 1% every year thereafter. So if you're talking about someone who's 80 years old and their creatinine, their serum creatinine, do we have any nurses in the audience? Okay, so if I start mentioning laboratory values, if I lose anybody, just stop me and I'll explain to you what it is. When you take a look at a serum creatinine, which is indirect measure of the renal functionality, it may show that it's fine. But in someone who's aged, for example, 80 years of age, based upon what I told you before, they've already lost 50% of their renal function. And that's if everything is well. That's not considering if they have renal toxic meds on board or what have you. So another aspect about renal function and determining it, it's very important to calculate that, and don't depend on the laboratory data that's in the medical record or chart or what have you, because what they do is they do a hypothetical calculation of creatinine clearance based on the serum creatinine. Unfortunately, it's grossly inaccurate and usually grossly underprojects the actual creatinine clearance. In pharmacy language, we use a calculation called Cockcroft-Gault, and I use a specific one related to Cockcroft-Gault lean body weight consideration. So when I calculate someone's renal function, I take out my calculator, I do what the pediatrician does, and I put in all the patient demographics, including height, weight, sex, and calculate exactly what's happening with that renal function in that individual. And it's usually very different and much more severe than what's reported in the laboratory data. So now that you know that most drugs that are on the market all have renal mode of elimination, that should heighten your interest. So special attention needs to be given to senior care drug selection. Commonly used drugs in the geriatric population include the likes of what you see right here. And they include very, very commonly used drugs like Neurontin. You're really seeing a lot of Neurontin lately, especially with diabetic patients, for the peripheral neuropathies. Lyrica, Bactrim. Bactrim's a very, very common drug in the nursing homes. Macrobid. Macrobid's an interesting point. I want to mention that if the patient does not have adequate renal function, Macrobid doesn't even work because it doesn't get to the site of action. So it's not uncommon. They'll put someone on macrobid, which was sensitive according to the culture and sensitivity. We'll go back 2 weeks later, and they still have a UTI, and they go to me, Don, what's happening? And I said, well, you picked a drug that's not working because it's not getting to the site of action. You have to have renal function for that drug to work. So very, very common problem. Metformin. You know, you see a myriad of patients on metformin. Zantac, digoxin, Dilantin, Cipro, Levaquin, Celexa, Aricept, Effexor, Namenda, Actinol, Fosamax, Remerol, Seroquel, Allopurinol. And this is just the tip of the iceberg regarding renal sensitive pharmaceuticals. So whenever I see any of these drugs, a red flag goes up, and I take out my calculator, I make sure I have the most accurate renal function, and usually end consults to my fellow physicians.